Oi, tô começando agora, tá? Agora eu não posso conversar. Tá, ótimo, obrigada.
Ok, cara.
Boa noite. Estamos começando nossa reunião científica de setembro, uma reunião muito especial. Nós temos um convidado internacional, o professor Shinji Tanaka, com a gente. E essa reunião vai ser toda em inglês. Contamos com um serviço de tradução simultânea e eu gostaria de explicar para vocês como acionar a tradução. Na barra de baixo, vocês vão encontrar um globo, um globinho, escrito interpretação ou interpretation. Se vocês não estiverem vendo, né, vai nesses três pontinhos, o more, ali vocês abrem o globinho. Clicando nele, aparece o áudio original, né? Você pode desativar o áudio original se quiser ouvir só o inglês ou só o português. Se deixar o áudio original e clicar em português, vocês vão ouvir as duas línguas, né? Talvez fique um pouco confuso. Essas regras, elas vão estar no chat, né? Quem quiser dar uma olhadinha lá, que o pessoal vai colocar para todos. Muito bem, vamos dar início então. Good evening. Tonight we have a very special guest join us for this meeting. We are very, very honored to have Professor Shinji Tanaka with us. Professor Tanaka is the president of Japan Gastroenterological Endoscopy Society and also of the Japanese Association of Capsule Endoscopy. He is Professor Emeritus of Hiroshima University and president of JA Onomichi General Hospital. He's giving us a lecture about magnifying endoscopy for colorectal neoplasia, present status and future perspective. Professor Tanaka, we can't thank you enough for joining us tonight. Thank you very much for sharing with us a little bit of your knowledge. I'm going to invite our moderator. It's Davi Lima. Eu vou apresentar o Davi em português, gente. O Dr. Davi é membro titular e especialista em endoscopia digestiva pela SOBED. Ex-presidente da SOBED, capítulo Minas Gerais, diretor e endoscopista da clínica Biogastro, endoscopista do Instituto Horizonte. Davi, be welcome.
Good evening, everyone. Thank you very much, Dr. Karen, for this kind invitation. I'm really very, very proud to be here, especially by side of Professor Tanaka. Between a lot of data that you mentioned about him, he has a very long curriculum, but I would like to mention one very important. Professor Tanaka has always welcomed us Brazilians with great warmth and friendliness at his department in Hiroshima, undoubtedly a reference in the world of endoscopy for the high level and scientific production. So I'm also, and you and Victor are one of his pupils. So this is also a great honor. So I'll introduce you Dr. Victor Arantes. He will be the debater. Dr. Victor is known from everyone here. He's an associate professor at the Federal University of Minas Gerais and coordinator of the Department of Endoscopy at Mater Dei Contorno and Mater Dei Nova Lima in Belo Horizonte. So please, Professor Tanaka, you have the word. Go ahead.
Thank you so much, David. I'm very happy to be here. So time is limited, so I will start my lecture.
have a lecture this time. Thank you so much, Karen, to invite me. Today, I'll talk about present status and future perspective of magnifying endoscopy for colorectal neoplasia. This is my COI. This slide shows chronological advancement of GI endoscopic diagnosis. At present, AI has been focused on discussion. Today, I'll talk about present status of magnifying colonoscopy, especially focus on NBI, and the future of this in the therapeutic aspect. Previously, there were several NBI magnifying classifications in Japan. I proposed Hiroshima classification in 2009. At that time, magnifying colonoscopy was not common outside Japan. Based on this situation, we established colon tumor NBI interest group CT-NIG in 2009 by the members of experts around the world as shown in this slide. The purpose was to propose a simple and useful colorectal NBI classification so that it can be used around the world. We propose the international NBI classification, NICE classification, in which magnification is not essential. This is NICE classification, simple three-category classification using color, vessel, and surface pattern. Type 1 is indicator for hyperplasia and SSL. Type 3 is for deep invasive carcinoma. Details of NICE classification is described in gastroenterology and GI. Please see when you have a time. This is our data relationship between NICE classification and histologic findings in colorectal regions. Clearly, type 1 is a good indicator for hyperplasia and SSL. Type 3 is for deep invasive carcinoma. However, type 2 includes various regions from adenoma to invasive carcinoma. As you know, in 2016, Professor Becker's group reported WASP classification. This is in order to distinguish between adenoma, hyperplasia, and SSL using NICE classification and standard colonoscopic findings of the region. By the way, in 2019, WHO revised the classification of colorectal serrated regions and polyps as shown in this slide. SSL is a new term for region formerly designated as serrated adenoma, SSA. Clinical guidelines on the management of SSA apply for SSL. SSL with dysplasia is used for those regions formerly called SSA with cytological dysplasia. In this revision, even single unequivocal abnormal run in hyperplasia is diagnosed as SSL. Generally, single round abnormality at the bottom of the crypt can never be diagnosed by colonoscopic observation. This case is mucinous carcinoma in SSL. Once dysplasia in SSL invaded to submucosa, its malignant behavior will get aggressive. We have to pay attention enough. Anyway, as for NICE classification, type 2 includes various regions from adenoma to invasive carcinoma. We cannot select the adequate colonoscopic therapeutic method. Next, I will talk about JNET classification. In order to solve this problem of NICE classification, as I mentioned, the Japan NBI expert team, JNET, in this slide was formed in 2011. Then we established JNET classification. JNET classification was reported at first in digestive endoscopy in 2016. This is the JNET classification. Simply saying, JNET classification is detailed classification of NICE type 2 subclassification. Magnification is essential to use the JNET classification. JNET classification is determined by vessel pattern and or surface pattern. surface pattern are both regular in type 2A. On the other hand, vessel and surface pattern are both irregular in type 2B. This is very easy to understand. When we use genetic classification, at first, estimation of the surface pattern should be done because we have a basic knowledge of bit pattern diagnosis. Type 1 is an indicator for hyperplastic polyp or SSL. Type 2A is for low-grade intramucosal neoplasia. Type 2B is for high-grade intramucosal neoplasia and superficial submucosal invasive carcinoma. And type 3 is for deep submucosal invasive carcinoma, respectively. This is our data published in GI 2017. We estimated about 3,000 consecutive cases of hyperplasia, SSL, dysplasia, and submucosal invasive carcinoma in relation to genetic classification. Type 1 is a good indicator for hyperplasia and SSL. Type 2A is a good indicator for intramucosal neoplasia. Type 3 is a good indicator for deep invasive submucosal carcinoma. However, type 2B includes various lesions and it was found to be a somewhat poor diagnostic indicator for intramucosal carcinoma and SM shallow invasive carcinoma. This is the review article regarding the diagnostic positive predictive value of genetic classification. As shown in this table, genetic type 2B show low diagnostic positive predictive value. This slide summarizes the strategy of diagnosis and treatment for colorectal lesion using genetic classification. When we detect a lesion, next observe it with NBI magnification and make a diagnosis by genetic classification. Type 1 lesion can be followed up. SSL larger than 10 mm should be resected by endoscopic resection. Type 2A lesion, most of them are adenoma are indicative for endoscopic treatment. Type 3 lesion, most of them are deep invasive carcinoma, needs surgical operation. As for type 2B lesions, we should add bit pattern diagnosis using crystal violet staining or EUS to characterize the lesion in more detail. It helps to determine the best treatment method for each case. This polyp is 4 mm in diameter. How do you treat? This is NBI magnifying view. How do you diagnose? This is JNet type 2B. For reference, two examples of JNet type 2A lesions are shown on the right. Compared to this, it is easy to understand that this lesion is JNet type 2B. JNet type 2B lesion is carcinoma, including SM carcinoma. So polypectomy is contraindicated and EMR must be performed. This is the cross-section of resected specimen by EMR. This lesion was SM deep invasive carcinoma. Using EMR, we could resect completely with tumor cut margin negative. I will introduce our new triple JNet type 2B subclassification. Based on the grade of vessel and surface pattern irregularities, we subclassified JNet type 2B into low and high irregularity as shown in this slide. Using our JNet type 2B subclassification, 82% of type 2B lesions is 2B low, and 99% of type 2B low lesion is indicated for EMR or ESD. This subclassification is very useful. However, this will not be common until JNet classification itself will be standardized around the world. We developed AI of nice JNet classification as shown in this paper. Here, I'd like to talk about the special characteristics of AI in the GI endoscopic field. Anyone can use AI to evaluate the same X-ray, CT, MRI, pathologic images, etc. However, endoscopic images vary widely depending on each endoscopist's skill level due to the various reasons shown in this slide. We have to use AI with understanding of the pros and cons where we must not be used or driven by AI. I will introduce the JNet virtual training seminar with Olympus. Considering the time difference, we started the seminar in Europe at first. For standardization of JNet classification, books or lectures are not enough to master. Case discussion with high-quality image is essential. High-quality image discussion with professional and GI pathologists, one-to-one precise contrast between endoscopic images and pathological findings are very important. Western endoscopists are distant from pathologists and lack collaboration. I think that this is the reason why magnification standardization has been delayed. Like in the first seminar last March. This is the next seminar that will be held 1 week later. These are faculties of the seminar. Now I have to tell the limitation of magnification. Magnifying endoscopic examination, including endocystoscopy, can diagnose the deep invasion of colorectal carcinoma. However, it is difficult to determine the degree of invasion depth and relation with muscle layer concretely. This is a flat elevated region 1 centimeter in diameter. Do you conduct EMR or ESP? This is a NVI magnifying view. Typical JNet type 3 with scattering vessels, avascular area, and amorphous surface pattern. This is indigo-carmine dyed spraying view. You can confirm depressed area clearly. This is EUS view with high frequency probe. Tumor is close to muscle layer, and muscle layer is swelling. These findings show that tumor is invading into muscle layer. Value enema shows trapezoidal deformity of chronic wall. We can diagnose that this region invades into muscle layer and surgery is essential. This is the pathologic findings of surgically resected specimen corresponding to preoperative diagnosis. Invasion depth of carcinoma is muscularis propria. This slide shows chronological advancement of GI endoscopic treatment. At present, full thickness resection and suturing have been focused on discussion. As shown in this meta-analysis, in colorectal SM carcinoma, it has been clarified that SM deep invasion is not independent risk factor for lymph node metastasis. In the near future, endoscopic resection as a total excisional biopsy might be common even for SM deep invasive carcinoma. I will show you one case located at lower rectum, 15 mm in diameter, 2A plus 2C lesion. Detailed observations show deep invasion with JNet type 3 and 5NP pattern. This is EUS view with high frequency probe. Tumor invades close to muscle layer and muscle layer is swelling. These findings show that tumor is invading into muscle layer. For several reasons, we conducted endoscopic full thickness resection for this region. thickness resection. This is after endoscopic suturing. This is resected specimen. This is the pathologic findings of resected specimen corresponding to preoperative diagnosis. Invasion depth of carcinoma is muscularis propria. In the near future, with advancement of endoscopic resection, magnification will be not enough to determine the invasion depth of carcinoma. US for prediction of the complete endoscopic resection will be essential for JNET type 2B or 3 lesion after magnifying observation. I will introduce the concept of EUS-TFD classification. Tumor-free distance, TFD, was defined as the distance from tumor invasive front to the muscle layer on EUS. As shown in this slide, EUS-TFD classification is classified into type A and B. Type A is defined as TFD is 1 mm or more. Type B is defined as TFD is less than 1 mm. I will show our study data. This study, using JNET type 2B high regularity 83 patients, 83 lesions, we estimated the predictive factor for tumor vertical margin negative after ESD using EUS-TFD classification. Tumor vertical margin negative defined as vertical margin greater than 500 micrometer from tumor invasive front to resection margin. These are the results of validate analysis. Significant predictors of vertical margin negative were tumor localization in the rectum, not located on the folds, and EUS-TFD type 2A. Also, fibrosis none or mild, good scope operability, SM invasion depth less than 2000 micrometer, and histology at the deepest invasive portion was observable were predictive factors for vertical margin negative. Multivariate analysis identified EUS-TFD type A and good scope operability as predictors with significant differences. Thus, EUS-TFD classification is a very important finding. This is 2A plus 2C lesion, 15 mm in diameter on the fold in sigmoid column. Magnifying view show JNET type 2B and 5L fit pattern, suggesting the deep submucosal invasion. EUS shows the submucosal layer remains between tumor invasive front and muscle layer. However, TFD is less than 1 mm. Type B, we conducted ESD for this region. Pathologic findings show SM deep invasion without direct tumor cut and positive, but tumor vertical margin is just positive because vertical margin is less than 500 micrometer from tumor invasive front to resected margin. Next case is front elevated region, 30 mm in diameter in rectum. Magnifying views show JNET type 2B and 5I pit pattern clearly irregular. How do you treat this region? MR, ESD? EUS shows that tumor invades close to muscle layer and muscle layer is swelling. These findings show that tumor is invading into muscle layer. Variable annular view shows trapezoidal deformation in lateral view. These findings show that tumor is invading deeper than muscle layer. Of course, we send this patient to surgery. Surgically resected specimen shows that tumor invaded into subserosa. Magnifying diagnosis for colorectal neoplasia is essential and should be standardized as early as possible all over the world. On the other hand, magnification alone is not complete. The combination used with EUS in case is necessary to estimate the complete invasion depth and to select the best therapeutic method. Finally, I will introduce the JGS International. We are delighted to announce you that the Japan Gastroenterological Endoscopy Society, JGS, has launched the JGS Official International Congress, JGS International, and the pleasure for us to have the first congress to be scheduled in September 5 to 6, 2025, next year, Tokyo, Japan. The president of the first congress is Professor Haru Inoue, and all the program will be held in English. This congress includes live demonstration and hands-on course. Please access to JGES homepage and confirm the details. I hope endoscopists from many countries, including Brazil, participate in this remarkable international congress and have fruitful discussions. We extend our cordial invitation and look forward to seeing you next September in Kyoto. This is a beautiful view of the Seto Island Sea from my hospital. Thank you for your attention.
Thank you so much.
Professor Tanaka, really impressive. Congratulations for this wonderful presentation. And we really appreciate your image and your experience because you are following this kind of research since many years, right? So to start, I'd like to ask you how these techniques are spreading in Japan. I mean, how about the learning curve for young endoscopists in Japan? They are changing the way the education, especially with this AI, because it's introducing now in Japan. Can you comment this for us, please?
AI is now detection AI is common in Japan, but for characterization, not so common, especially in colon. And to master, to spread NBI magnification, case discussion with professional endoscopists and GI pathologists is very, very important. Many lectures, many books exist, but they are alone not enough to master the NBI diagnosis. Discussion with good cases, very, very important. So I prepared several cases. Let's discuss after our discussion.
Okay. Victor, would you like to comment and make any questions to Professor Tanaka?
Oh, yes, sure. So good evening, everyone. First, I'd like to thank Sobed Minas Gerais for the honor of inviting me to participate in this wonderful webinar. And it's so good to see again here, David. We were together working back in 2000, I think it was 2003, when David coordinated the invitation to Professor Tanaka to our workshop in the Alpha Institute of Gastroenterology. And Professor Tanaka came and performed various live cases, and we learned a lot at that time. I'm sure David will remember that. And afterwards, I could visit his unit in 2007, and I was really impressed with all the staff and the conditions of the Hiroshima University. So, Sensei, thank you so much. This was a wonderful lecture. And I was really interested in your comments about the role of endoscopic ultrasound for colorectal lesions characterization of invasion depth. The reason I was impressed is because in the past, we were paying a lot of attention on US for early cancer staging. And then we moved in direction of image-enhancing endoscopy, magnifying endoscopy for staging, particularly in the esophagus, but also in the colon. And now what I notice is that you start again in your center to develop an expertise in EUS also to do this staging for colorectal lesions. So I have a question for you because all your case was using mini probe EUS. Do you think it is feasible also to do this kind of staging with regular echo endoscopes, like a radial echo endoscope or linear echo endoscope, a dedicated echo endoscope? How is your impression about it?
Low frequency regular EUS is scope operability is bad. So in deep colon, it is difficult to diagnose. Also, recently high frequent probe shows various frequency. So at least region for endoscopic treatment or surgery, borderline regions are enough to diagnose by high frequency probe. We can scan basically on the region surface, but sometimes we approach both lateral side. This complementary technique for high frequent probe.
Yeah, indeed, I agree because as a US operator, I think it's very difficult to do a nice staging with a linear scope or even a radial scope. And we used in the past also the mini probes for staging of early cancer. And it's much different from the dedicated echo endoscope. So I think we need to emphasize that the data you have been demonstrating is using high frequency probes and not a dedicated EUS machine. Another question I have for you, Sensei. Now we have such a sophisticated imaging technology like NBI, BLI, magnifying endoscopy. But we appreciate that the Japanese still do the standard staining like chromoendoscopy with indigo carmine. So could you share with us what do you look for when you do the indigo carmine staining? What is the role of this staining for the appreciation of colorectal lesions?
After NBI spreading, needs of indigo carmine decreased. However, to determine the gross appearance, such as LST pseudo-depressed type, to distinguish clearly between a flat elevated region or flat elevation with depressed area. For this, indigo carmine dye spraying essential. For crystal violet staining, only type 2B region is indicated. After NBI standardization, in clinical practice, indigo carmine, crystal violet staining use decreased. However, in academic center, to gather data, we do all procedures. In daily practice, not so many necessity. Yeah.
I want to follow the question from Victor Tanaka. Look, in Brazil, we don't have the scopes that you showed us and the high technology in many places. So, because first of all, because it's very expensive, and second one is time consuming. But in Brazil, we still have problems for detection. We know in general, there are a lot of small lesions and small cancer, minute cancer are not detected. You told us that in Japan, maybe this is not a problem because endoscopists are really trained to detect small lesions, right? And second one, you said about characterization. So I think the main purpose of these new technologies is characterization to decide which technique and which conduct you should follow in these patients, right? So, do you think the indigo carmine staining, the conventional staining, help us to improve detection with high resolution scopes? Do you think, because I saw some colleagues performing indigo carmine, for example, I use by myself, when I spread it in right column, it looks like I can detect more lesions, especially serrated lesions. What do you think about? Do you think this is useful for detection to help us with high resolution scopes in right column?
Yeah. First, preparation is very important. In bird preparation, indigo carmine dye spraying is very bad. And in old days, there are several studies on significance of indigo carmine dye spraying for detection of the lesion. At that time, resolution is not so high for colonoscope. Recent electrocolonoscope is very high resolution, and we can see fine network pattern without dye spraying IE. So, in my opinion, indigo carmine dye spraying is not so useful for specialists.
Okay. So in Japan, you don't use, but okay, in Brazil, maybe because we don't have the chromendoscopy, the electronic and digital chromendoscopy. So maybe sometimes. Okay, Victor.
Yeah, I have another question for you, Sensei. I was really impressed also with the workup when you include the barium enema for the characterization of neoplastic lesions, early neoplastic lesions, not advanced tumors, but perhaps some muscularis propria invasion lesion that you need to decide. And this technique is now very seldom used in our centers in Brazil for this kind of characterization. So I would like to ask you, how often do you use these, and what are the information that you are looking for in the barium enema that is helpful for your decision in the decision-making process for indication of endoscopic or surgical treatment?
At first, barium enema is not effective to large lesion or very large elevated lesion. 1 centimeter, 2 centimeter, mass 3 centimeter relatively not so high, not tall lesions are very good indication. If we can get precise diagnosis by EUS, we don't do barium enema in practice. But if EUS is very difficult to determine the concrete invasion depth, we add the barium enema. Relatively small and not so high lesion is a very good indication.
And in this same point of discussion, is there any role for CT scan for trying to look for the same information? For, I understand, it's more intermediate size lesions, not sessile large polyps. And how do you compare the information you get with barium enema and perhaps CT scan? Because at least in Brazil now it's very difficult to find radiology departments that are still willing to perform the barium enema. So is CT scan a possibility of imaging method that could be useful also for this kind of assessment?
I don't know. I have no data. But CT is effective for diagnose lymph node metastasis.
And we want to know if there is some questions from the audience. You can send questions with the chat. And Tanaka, you showed us you are introducing the full thickness resection. How do you think about the future for this technique? It will be available and reproducible for many centers, or it really takes a long time for learning and to use and to spread this technique? What do you think in practical?
Yeah, full thickness resection is needs high technique, and if adverse event occur, patient have bad clinical course. So full thick resection has been discussed in US or Western country. Japan is delayed. So 5 years ago, Professor Haru Inoue developed the full thickness resection research conference in Japan. Now in Japan, just in discussion, whether this technique will be common or not, maybe will be common for special colonoscopists, but now under discussion and under research state.
Okay.
Yeah, I'd like to add one more question in this same situation. I mean, patients that may have a deep submucosal invasion lesion. And you mentioned your study that when this is the only non-curative criteria, like a deep submucosal invasion, like 1,500 micrometers or 2,000 micrometers, and the lesion is resected en bloc, and with R0 resection and no other histological features, do you think we could just go with follow-up? And I'd like you to respond that in the colon and in the rectum, if it's the same approach, how do you think we could be confident on not indicating not a surgical rescue surgery in case we have a deep submucosal invasion?
Yeah, if submucosal deep invasion more than 1,000 micrometer has no other risk factor for lymph node metastasis. Based on our Japanese detailed data. Lymph node metastatic risk is 1.3%. 1.3%. We have to compare the patient background, age, complication, their disease or location of the region, etc. And patient will. These three factors should be considered simultaneously with patient. There is, how do you think of the risk 1.3% for lymph node metastasis? In Japanese data, common colorectal surgery occur patient death with complication 0.3%. So operation risk, lymph node metastasis risk, patient will, and patient background. We have to consider the follow-up or additional surgery. So we can determine only one way. There are various factors we have to think.
And Professor Tanaka, how about the AI? I mean, in Japan, it is improving. There is a lot of work on it and a lot of papers and cases. So nowadays, do you think AI is possible to help really the endoscopists to characterize for the characterization of the lesion and show what's the best management of them?
AI is now remarkably developing, but now only first step of development. Maybe 10 or 20 years later, AI will be used commonly for endoscopies. But at present, AI was made very good special image from specialist. Do you understand? As I mentioned in my lecture, endoscopic skill vary. So if bird image, using bird image, AI will misdiagnose. So different from CT, MRI, etc. GI endoscopic AI for GI endoscopic AI, not only AI, but endoscopist skill is essential. So AI alone will be impossible.
Yeah. So the endoscopy needs to help AI, right?
Yes, yes. So endoscopists can be alive.
Yeah, because you need a good prep and need a good position of the scopes and to know how to look behind the folds, etc. Right?
Yes.
So that's nice. But if the image is good and the endoscopist has a good preparation and we detect the lesion, so when from this point to start the AI, the characterization will be confident or not? Not for detection, but for characterization, I mean, with a very good, clean image. And it will be possible to be better the eye of the endoscopist.
Maybe for beginner, very effective.
Mm-hmm.
I have to mention one important point in my lecture and this discussion. For AI or not for AI, for using NBI or BLI magnification, every endoscopist pay attention to vessel, because vessel is very clear and brown and easy to observe. However, to estimate the surface pattern, if best focus is not obtained, even if surface pattern exists, maybe images show non-structure. Do you understand? So
Yeah.
we have to adjust the focus enough to diagnose the surface pattern. Then we can diagnose the NBI-BLI magnifying view correctly. Vessel can be seen with not enough focus. So completely focus adjusted view is very, very, very important to use genetic classification. Please understand and keep in your mind.
Okay. So now you have the cases to present.
But time is okay. So
10 minutes.
Huh?
We have 10 minutes.
Okay, so just a moment. Can you see?
Yeah.
Do you see my slide?
Yes, perfect. Go ahead.
Yes, Sensei.
This is a tiny polyp. This is NBI view. How about your diagnosis and treatment plan? This. How about David? JNet type? Maybe general colonoscopist do cold polypectomy only by this standard view. However, NBI magnification shows regular vessel and regular surface pattern. You can see pit-like pattern, but margin of pit-like pattern is very irregular. So we have to do EMR, not polypectomy. Polypectomy, including cold polypectomy, cannot get enough submucosal layer. We have to do EMR. We do EMR. This region shows SM deep invasion. If we conduct the cold polypectomy, deep cut margin positive. Okay? Like this, NBI magnification, BLI magnification is essential for determining to do cold polypectomy or not.
Sensei, one question for this case, very interesting case and very surprising. What about the cold EMR? I mean, using the submucosal injection to elevate the lesion and then cutting in the cold resection. How do you see? Is there any role for cold EMR?
I have no experience of cold EMR. By cold EMR, we can get enough submucosal layer.
Actually, there are a few studies about it. And I think we are much more comfortable with the standard EMR, I mean the hot snare EMR. But I've been observing that people have advocating more and more this cold EMR because of the decreased risk of delayed bleeding.
Yeah. Anyway, injection support and help the snaring. However, if we don't use generator, we cannot cut muscular mucosae. So maybe we cannot get enough submucosal layer. Cold resection should be used only into the mucosal region. Okay. Next. This is LST-NG, 3 centimeter in sigmoid colon. This is indigo carmine dye spraying view. Depressed area became clearly. 2A plus 2C. LST-NG pseudo depressed type. This is NBI magnifying view, yellow at the yellow part. How do you diagnose? Vessels is scattering and vascular small area exists and the surface pattern is unclear. So this is typical JNet type 3. This means SM deep invasion. We send this patient to surgery. As shown in slide, at the part of NBI magnification, cancer invaded close to muscle layer like this. Last region. This is LST-NG on the fold in rectum. This is indigo carmine dye spraying view. Like this, indigo carmine dye spraying view is useful to detect the depressed area. Depressed area, flat region with depressed area has high incidence of submucosal layer, especially LST, as for LST-NG pseudo depressed type, irrespective of pit pattern or NBI findings. Even if regular surface pattern, high incident of SM invasion. Anyway, this is NBI magnifying view and crystal biopsy staining magnifying view. Irregular surface pattern, irregular pit pattern. We do ESD. Massive invasion, but far from muscle layer. So we judged we can reject this region endoscopically completely. Then we do ESD. We can get complete resection. This is rejected specimens pathologic findings. At the irregular area, surface structure remains, but at the deep part, cancer invaded deeply. This region shows high-grade budding and lymph vessel invasion, also poorly differentiated component. So we had additional surgical treatment for this region. This is all three cases I prepared. Like this, NBI findings and for some cases, EUS are very, very useful and essential. Thank you.
Thank you very much. Really illustrative. Your cases show us that the detail and characterization is essential for the management, right? Unfortunately, we don't have these techniques spreading in Brazil. So many times there are under treatment, or sometimes we have treatment that are not appropriate for some lesions. Thank you very much, Tanaka-sensei.
Thank
Vitor,
you.
to the last comment. And Tanaka, would you like to send us your last message for the Brazilian endoscopists?
Yeah, thank you so much for attending this wonderful seminar. Brazil is my second home mother country, and I love Brazilian, and I hope magnification and NBI, BLI magnification will be in common, standardized soon. Thank you.
Thank you very much. Thank you. Thank you very much, Victor,
See you.
for participation. Thank
Thank
you,
you,
everyone.
Sensei. It was really very, very, very nice. We learned a lot. Incredible. Thank you so much.
Thank you so much. Karen, thank you.
Karen, please.
Thank you, Sensei. Thank you very much for this excellent and very profitable lecture. And I would like also to thank Vitor and Davi for this high-level discussion. Well, Tanaka-sensei, thank you again for your kind of ability to give us this lecture and discuss with us later. We know you're extremely busy in this moment, so again, we are very honored to have you here tonight.
Thank you so much.
Before going, I will leave the word with Victor for some information about the SBAD 2024. Please, Victor.
Oh, yes. So we are getting closer to Brazilian DDW. It will be from November 21, 24. We have a symposium with the Japanese Society of Gastroenterological Endoscopy Society. This will be on, I think, on Saturday. So everyone is invited. And we have also the video tournament. So I encourage everyone to send those high-level videos that they will be classified. And for Minas Gerais, only one place available. Each state will have only one competitor. So please submit your videos for Brazilian SBAD. I hope we can have a nice video from Minas Gerais for this tournament. Thank you.
Thank you, everybody.
Thank you.
And
Bye.
bye-bye, Sensei. Arigatou gozaimasu.
Bye-bye. Thank
Bye-bye.
you.
Bye. See you again. See you soon. Thank you.
See you soon. I hope
See you,
so.
Sensei.